These are the drug names you may remember, but these drugs, they are not the best ones. They have side effects. They are maybe not that potent as the second wave. So there will be better protease inhibitors, and these at least 5 compounds, and you have to believe me again, that with these compounds you may achieve undetectability of the virus by week 4 in about 85%, and several compounds have been described also during the recent liver meetings. The other class of compounds are so-called polymerase inhibitors, and there are 2 different classes of polymerase inhibitors. One are nucleosidic polymerase inhibitors, and the other one are non-nucs. They have different properties, and the nucleosides most likely are less prone to resistance than the non-nucs. They have a broader genotype, or they work against different genotypes, but these drugs are not that advanced. Again, there are several compounds in development. The first drugs that we may have in our clinics will be approved not before 2014. And then there are several other targets, so-called NS5A inhibitors. It's quite funny. We have extremely potent drugs targeting the NS5A protein of hepatitis C. We know already we have inhibitors, although we don't know what this protein does, which is quite interesting. So we are more advanced in drug development than in understanding the virology of this virus. Cyclophilin inhibitors are in development, then a wonder drug, nitazoxanide. We don't know really what the future will be. And then there have been interesting data from Vienna, silibinin, which is interesting, has also a potent antiviral efficacy, and several other compounds are in development. So it's impossible to keep track, and also on the interferon sides, there are many interferons that are in development, which may also improve side effects and efficacy of the interferons. So many compounds. And why, again, do we don't have these drugs available yet? I just last week saw a patient which I saw for the first time in 1997. He is very well educated. He reads Nature and Science. And he showed me in 1997 the first crystal structure of the HCV protease. So then he was asking me, when can I have a drug against this crystal structure, against this problem? And then based on the experience at that time on HIV, I told him, well, maybe 5 years from now we should be ready. Then I told you, and he came back 5 years later, asked me when I can have the drug, and I told you, yeah, we started just the first exposure, so in 5 years you may come back, and then we may have the drug. And then he came back now 7 years later and asked me, when can I have the drug? And I told you, well, maybe in 4 years you may get the drug. So it's really a problem. What are the challenges and what are the problems? The first one is all these drugs may cause resistance, and they may persist. So it's very difficult. We have to be very careful in exposing our patients to these compounds with suboptimal treatments. Resistance emerge within days, and they may persist for several months, even years. These resistant variants may persist. The second problem is, as I mentioned already, all trials are still in combination with interferon and ribavirin. And you all know about the side effects, you know all about the limitations, and this is something, if patients went through interferon and ribavirin, if they are not be able to tolerate this treatment, they still will not benefit within the next 2, 3, 4, 5 years, because we don't have a trial really aiming for cure of HCV infection without the compounds. And importantly, we also have to stay with ribavirin. Ribavirin will also stay on board. This is one trial that showed that leaving out ribavirin from the treatment regimen does not work. Question is, of course, if we still have to go with ribavirin and interferon, we may need to go back and try to understand why actually interferon does not work in chronic hepatitis C in a substantial number of patients. And I don't want to go into detail, I just want to mention that the virus is extremely clever. He has developed many ways to circumvent interferon response waves, and one is that certain pathways in the cell, how interferon is signaling, is blocked directly by the virus. And the idea was, if you add these new protease inhibitors, that by that you can also restore the function of interferon. So you would have a double function of these protease inhibitors. On the one hand, you directly block the virus. On the other hand, you may restore sensitivity to interferon. This was the idea. And There was one paper last year published by Stan Lemon's group saying, yes, indeed, this is possible. However, we will never achieve a sufficient dose of these compounds in vivo that this restoration of interferon may indeed occur. However, the good news for the patient is that it may work. So if patients who have failed to previous interferon therapy are exposed to triple therapy, interferon plus these protease inhibitors, the first trial was presented earlier this year at the EASL meeting, showing that in previous non-responder patients, cure rates of about 39% were achieved. And very promising data were just released at a press release by Vertex, who is running these programs on telaprevir, showing even higher response rates of 57%, which I think is really promising. And we have, this is the good news for non-responders. These drugs in combination with interferon most likely will work. What we are now playing in real life is how to combine these new compounds with the standard of care. And for some drugs, it has been suggested that we should not start immediately with interferon, ribavirin, the new compounds, but that we first start with interferon, ribavirin, and then only add the new compounds after 4 weeks. Why that? If you would start with the lead-in strategy, the advantage is that you, of course, during these 4 weeks would identify those patients who are not tolerating interferon treatment. And by this, of course, you would ensure that combination therapy is only given if you have the full dose of interferon ribavirin, which is necessary to prevent resistance against the new compounds. And those patients actually who after 4 weeks become negative for HCV RNA, so are very good responders, they may not need at all a triple therapy because they have cure rates of about 85% anyway, or 90%, which is the good news. And meaning that only those patients with an intermediate response, you would give triple therapy, which is about 2/3 of patients. And then there was a question, those patients who do not respond during these 4 weeks of lead-in, what to do with those patients? Is it dangerous to expose those patients then to the new compound because they do not respond to interferon ribavirin? Again, is this then a monotherapy with these protease inhibitors, which will lead to resistance within days? Or does it somehow work? Do patients still benefit from this? And just 2 weeks ago at the American Liver meeting here, the first data of this concept were presented, showing that you may have some patients who indeed still can respond, and if you have patients who have within the first 4 weeks of treatment less than 1 log decline, that if you then treat them for 28 weeks, only 25% of those become negative, but if you treat those patients longer, then still half of those patients cure the virus. So meaning this lead-in phase could be helpful in identifying those patients who require shorter treatment or longer treatment with these new compounds. The final question, of course, is if we still have to go for interferon, can we identify patients even before treatment if they respond, yes or no? And there have been thousands of studies, thousands of factors being associated with interferon response. Obesity is bad, being male sex is bad, and overweight is bad, co-infections are bad. But the most striking factor has been identified this summer. And there have been several papers performing a genome-wide search for polymorphisms and looking if there's a genetic factor identifying responders versus non-responders. And this is really fantastic data which have been published this summer by different groups from Australia, from the US, and from Europe. And what they did, I really like this slide. This is from a Japanese paper. You can see here each tiny little dot is one polymorphism, genetic polymorphisms being associated with a certain level with clearance of the virus by treatment, yes or no. And it's plotted against the p-value, so how significant this association with clearance was. And you can see here there are many, many dots with 10 to the minus 3, 10 to the minus 4, which is already highly significant. But then there were 2 tiny little dots up there on the right side, which 10 to the minus 11 and 10 to the minus 13. So really showing how strongly these 2 genes are associated with response to interferon treatment. And I think in future this will change treatment because we have to test for this polymorphism to really identify patients with a higher likelihood to respond and a lower likelihood to respond to treatment.